Good morning, everybody. I'd like to welcome you to this live stream conversation with Dr. Vinay Prasad. My name is Vincent Kelly. I'm a PhD student at the University of Pennsylvania, and I started a petition against the COVID-19 booster vaccine mandate at the university a couple months back. And since then, I've been able to meet a number of like-minded students, and we have recently formed an organization called the Penn Anti-Coercion Coalition. And some of the people at the table today are from this coalition, and we've also brought in some others also at Penn, but not officially a part of our group, in order to have a wide-ranging discussion with Dr. Prasad. So the Penn Anti-Coercion Coalition is a group of UPenn community members across the political spectrum opposing exclusionary COVID-19 vaccine mandates. And I really want to emphasize that we're from across the political spectrum. We have people from the left, from the right, and everywhere in between, whatever those categories mean in 2022. And I think this is very important to remember, especially in this highly fragmented and divided political climate, that these are issues that many people care about, and oftentimes it's just a feeling of perceived disagreement from peers that prevents people from speaking out. So we're trying to rectify some of those issues on campus by bringing people from many different backgrounds and many different schools together. And, you know, just at this table alone, we have people from engineering, biomedical graduate studies, law. I myself am from the music department. So we have a diverse array of students and faculty and others involved in this work. And I'd also like to just extend a thank you to Bill Bollinger, who is with us today, who's been a longtime supporter and donor to Penn, for his immense generosity in helping make this event possible and bringing Dr. Prasad here from San Francisco. So I'll just briefly introduce Dr. Prasad, and then he'll give some short remarks, and we'll be able to get into the Q&A. So we'll start with a live Q&A with those participating in the room here, but if you're on Vimeo and Rumble, we're streaming on both of these platforms, and you're able to type your questions in there for Dr. Prasad and any other things you want to contribute to the conversation. I believe on Vimeo, you do have to log in to type a question. On Rumble, I don't think you have to have an account. So if you're on one of those platforms, you should be able to participate in those two ways. Rumble is a little bit easier as far as participation. So Vinay Prasad, MD, MPH, is a hematologist oncologist and associate professor in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. He runs the V.K. Prasad Lab at UCSF, which studies cancer drugs, health policy, clinical trials, and better decision-making. He is the author of over 300 academic articles, as well as the books entitled Ending Medical Reversal, which was written in 2015, as well as Malignant, written in 2020. He hosts the oncology podcast Plenary Session and runs a YouTube channel under the username Vinay Prasad, MD, MPH. So without further ado, I'd like to turn it over to Dr. Prasad for some opening remarks in today's conversation.
Thank you so much. Thank you for having me, and to those who are joining online. It's been a pleasure to meet you, Vincent. It's a pleasure to talk to you, Bill, and to get to talk to you all this morning over breakfast. So in terms of background, I'll just add a little bit of background to that. I'm a practicing heme clinician, so I'm in clinic a couple days a week, and I attend on service several months a year. So I have the clinical side of things that I can talk about. I think it'll be pertinent to maybe some questions you all have. I do research in epidemiology, biostatistics, and that's been my interest for some time. And you mentioned the political point. I guess just to be fully transparent, I'm actually someone on the extreme political left. I'm a supporter of Elizabeth Warren, Bernie Sanders, and that's always been where my sentiments have lied. But when it comes to COVID-19, I think I'm trying to think of broadly holistic, pragmatic strategies that benefit the most people. And like you, I think I'm concerned with some of these mandates. So you asked me to talk a little bit about college and COVID. And I guess I'd say a couple things. First, I would say that it was known very early on that COVID-19 is something to take very seriously. It's a serious threat, but it has a huge age gradient. the risk of a bad outcome in an 88-year-old versus an 8-year-old, it's not just 10 times higher or 100 times higher. It was 8,007 times higher. That risk by age, that gradient, was the steepest, I think, single epidemiologic risk factor we've ever seen in biomedicine. And I think it has implications for policy both in 2020, which we don't have to go and rehash all of 2020, but it certainly has implications for today, which is that we're talking about college students who generally are in their early 20s to mid 20s. College students face much, much lower risks than older people. And at the same time, if you look across America, it appears to many observers that college students are subject to the most restrictions. Restrictions on, I think, what they can choose to do in terms of booster shots, even more so than some faculty at universities, including faculty who take care of patients. I know some universities where they don't have booster mandates, but yet you all do as college students or as graduate students. I think the other places in which it affects your life are mask mandates, which we could talk about if you wish, and also restrictions on who you can meet with and size of gatherings and where you can eat dinner and lunch. And so college students have borne enormous, I think, restrictions throughout this whole pandemic. And it is not the group that has the highest risk of bad COVID outcomes. And now we're in a post-vaccination world. We're almost 1 year, 1 year to the date where every American had an access to a vaccine. And I think we need to be talking about strategies for COVID-19 that balance the serious risk it remains, particularly to older, immunocompromised, and vulnerable people, while allowing, I think, rest of society to kind of get back to normal and to make choices that are compatible with their own desires, which is always sort of an important principle in biomedicine.
Thank you so much for those comments, Doctor. So I think right now we'll just open it up to any questions that people might have at the table. I'll just start off with one kind of general question. I guess it's kind of a hard one as well because it's sort of a political one, but why is it, in your opinion, that colleges and universities have had largely the most stringent and restrictive COVID-19 policies, be they around masks, vaccine mandates, limits on social gatherings? Could you just talk about why you think that happened, especially as somebody who's involved in a university yourself in academic medicine?
Yeah, that's a good question. I guess I would say that if you were to step back and look at all of the places in which mandates have been placed, and all of the places where you wish you had placed a mandate. And by that I mean, I think if one were to think about this problem broadly, one would say that the people I really want to make sure who are vaccinated are older people over the age of 50 or 65 or 40, you pick the age cutoff, but older people who have never had or recovered from COVID-19, I need to make sure every single one of those people has at least one dose in the arm. I think that would be a very sensible strategy because that's the greatest risk reduction in a single effort. Many of those people are older people, 70, 80. That's where that's the first place you want to tackle. But if you look at the policies we've enacted, from employer-based mandates through mandates that were recently struck down by the Supreme Court, to healthcare mandates, to college mandates, to things we do in grade school, you will see that we have put a lot more force and pressure and coercion on younger people. And in part, I think that reflects the fact that there are not great political levers to coerce older people. And I think that is something that's true at a federal level. And that's one of the reasons why the United States lags many of our developed peers in terms of vaccinating and boosting older people, which I think was incredibly important. Why college kids? And why, I think, to some degree, we can ask why elementary school kids and preschoolers were the last to unmask. I think these are places where there's an asymmetry in power. I mean, the administration has sort of your future in their hands. I mean, these degrees that you are pursuing are important for your intellectual development, but they're also deeply important for your prospects in this world in terms of what jobs you can get and what life you will lead. That's why they charge such a premium for these degrees. That's why people are happy to pay whatever these universities wish to charge, and probably even more if they were to increase them in the future. And so they have a tremendous power over you that you really need that degree. And so policies that pressure students to be boosted in order to get that degree and then disenroll them in some universities, not necessarily yours, if for not doing that, they have tremendous leverage over people. I also think there was, at one moment in time in this pandemic, a thought that even if we don't get all those 65-year-olds vaccinated, there's going to be some herd benefit. If we can get everybody over the age of 5 vaccinated and get those numbers really high, we will protect these people indirectly. But then I think a couple of things came along that shattered that notion, and in fact led the CDC to rescind their language around herd immunity. One of the things that shattered that notion was that the R coefficient, the measure of transmission, jumped precipitously. And herd immunity is a mathematical equation that uses that R, the level of spread, and when R goes really, really high, herd immunity can go to 100% or more. It's no longer a threshold you can meet. And then the next thing is breakthrough infections. I think we learned that although these vaccines are tremendous at protecting you from severe disease, they are not able to keep you from having a breakthrough infection. And those two things, I think, ensure that there's no amount of vaccinating 5-year-olds or 12-year-olds or 25-year-olds that will protect the unvaccinated, non-immune 88-year-old. That person is as vulnerable today as they ever were. And I think that's an important point that has shifted along the way, and maybe policy hasn't shifted along with it.
We came up with some questions beforehand. I'll just read one of them that I feel strongly about. So I think that the opposite of coercion is persuasion. And when you choose coercion as a policy, it brings up ethical questions. And my question was, when making policy decisions, the ethical values undergirding one policy option may conflict with the values underlying another option. In other words, when one public health decision is made, certain values and goals are promoted over others. There's a cost, benefit, and conflict. What would you say when it comes to the potential conflict between bioethical values, such as bodily autonomy and informed consent, and public health values, such as decreased transmission and hospitalization rates, as the data show? And can you talk about those two values or sets of values as they relate to COVID policy?
Yeah, I'm happy to do that, but I guess just to sort of, I don't want to concede anything I don't believe is true, and so let's just talk about what I think the boosters do. Mm-hmm. I am persuaded that in older people or vulnerable people that boosting does further reduce the risk of hospitalization beyond the impressive reduction of the first 2 shots. I'm persuaded of that fact through a number of different observational data sets that I think that's true. That even though there may be some other sort of residual problems in those data sets like confounding, I think that the effect size is so clear that we can have some confidence that it cannot be fully explained by other things going on in the data. But let's talk about you all, people who I think, healthy people who are mostly on colleges' campuses between the ages of 18 and 28, for instance. I think I'm not totally persuaded that between 18 and 28, a healthy person has an additional reduction in severe disease or hospitalization from getting that booster. There's also the risks to that person in terms of side effects. And I think one noted side effect of mRNA vaccination has been myocarditis or inflammation of the heart. Many people like to say that it's mostly mild. I'll tell you that inflammation of the heart, myocarditis, I think, it's never a trivial thing. I mean, this is putting people in the hospitals, even for observation. I think it's something that is undesirable. We wish this vaccine didn't have that side effect. Of course, the second dose, when given in close proximity to the first dose, has the highest rate of myocarditis. And it's higher for Moderna than Pfizer, and it's higher in men than it is for women. And that second dose is the highest rate. The booster, it's not as high as the second dose, for sure. But it's not zero either. It's something in between. It is a lower rate of myocarditis, but it's not absolutely zero. And so when you're just thinking about the individual policy prescription of boosting someone who's healthy in this age demographic, I think there is uncertainty as to whether or not it is in that person's best interest. We do know with some confidence that it will reduce your risk of having a breakthrough infection in the short term. Some percentage, it'll have a short-term reduction in breakthrough. But you may have a breakthrough anyway with further follow-up. No amount of boosting may forever prevent a breakthrough, and most of those breakthroughs are going to be mild. But will it further reduce your risk of severe disease or hospitalization? And is that benefit so big it outweighs any harm of the vaccine for the booster in that age group? I think there's uncertainty. And I think that uncertainty is reflected in the fact that Paul Offit, who is one of your faculty members and a leading proponent of vaccination, he himself has been skeptical of that claim, and quoted in The Atlantic as saying he advised his own son, who's in that age group, not to get boosted. The other thing I would say is that there's other people who are experts in this space who are concerned that the balance was unfavorable, and 2 of them are Marion Gruber and Phil Krause, who are the deputy and director of the FDA Vaccine Products Division. and they felt coercive pressure from the White House to approve vaccines. Here we're talking about emergency use authorization for boosting in this age group, and they resigned over that. They'd rather resign over doing that action, which they felt was not justified by the available evidence. So I guess the first question is, as a prerequisite for the ethical question, because you're asking to balance two things, and the balance would be the personal freedom and autonomy of an individual to choose a booster, and what we're saying and your policies are saying is we're going to override that. But presumably to override that, you need to have some confidence that there prima facie is some greater benefit to other people, or at least some benefit to other people. I think you have not only failed to demonstrate that, because I don't know if you all being boosted makes Penn campus any safer. I certainly don't know if it makes it any safer 2 months from now, 4 months from now, 6 months from now. I don't know that that's going to have a great benefit on the transmission dynamics across the city of Philadelphia and across your campus, where my understanding is half the undergraduates don't live on campus anyway. And we have a rest of society that's returning back to pretty much normal. I don't know that it's going to confer any benefit to the individual or to others. I think that's still uncertain to even have this sort of ethical tension in the first place. And so I would say that I think personally, and medical ethics has always felt, that the bar should be rather high to erode someone's personal healthcare choice for a personal health decision. That bar should be high. And in this case, I think you don't really even have that conversation. I think we just need to get a lot more data, I think, to even build a case.
Kind of to follow up, you were talking about you're talking about building that case of is the policy, public health policy of us all getting boosted, going to above and beyond create a much safer situation to the point where it overrides other values or even rights.
Correct.
So I remember reading a test negative case control trial where they were looking at first dose, second dose, and booster during the time periods of Delta and Omicron. And this recently came out, and my understanding was that they were showing, I couldn't really figure out exactly the math of it, but it was they were saying that the booster did have some effect at, they decided that the likelihood of getting Omicron was less than if you were boosted than if you were double dosed or single dosed. But my problem with this study, I think that it's interesting that this study is I think able to be used as here's some evidence showing the effectiveness of the booster, but my confusion and concern about this kind of study is the test negative case control situation, which is that the patients that they were gathering data from were people who were symptomatic enough to go to a pharmacy and get tested. So does that not skew everything to, say you have people who have COVID, they can test positive. There's a group that's symptomatic, and then understandably so there should be a group that's asymptomatic, but would not be considered in this study. So how are we able to determine whether the real effectiveness of the booster if we're only looking at symptomatic people and not asymptomatic people?
Yeah, I guess, okay, a few thoughts. I mean, one thought would be that most of these studies that have looked at is the rate of having some symptomatic breakthrough. And I think many of them are converging on the idea that giving somebody a booster means you have a slightly lower chance of some symptomatic breakthrough in a short period of time. But after the time goes past, the effectiveness, the vaccine effectiveness diminishes to the point where we're really unsure 8 months or 10 months after a booster if it'll have any benefit over just the primary vaccine series in having a symptomatic breakthrough. And we should be clear, here we're talking about symptomatic breakthrough, which pretty much is cold or flu-like symptoms that many people are having. And in fact, at this point in America, I think many people have had breakthrough infections after being vaccinated or vaccinated and boosted. And it's not the same, I think, severity and life-threatening event as it would be to meet COVID-19 without ever having had a vaccine in your arm before. So that's what we're talking about. So even if one were to prove that this endpoint is met, I think you still have a debate as to whether or not it is high enough of a bar to justify coercively pressuring people to get the vaccine, even if it is met. Now, your point about test negative design, I think, is a good point, which is that I would say, and the way I would articulate it is this. One of the assumptions of it is that everyone who seeks testing is seeking testing because they roughly have the same symptoms. And this test negative design is often used in influenza to infer the effectiveness of influenza vaccine season to season. But with COVID-19, there are different reasons why people get tested. Now, some people get tested when they feel unwell or feel sick, but other people are getting tested as part of routine surveillance. My understanding is that even you all have bi-monthly surveillance if you so choose, and many employers have surveillance. And the people who get tested routinely or get tested for travel to go to Hawaii or get tested because a school requires it or because they need it to check a form or they're going to have an elective procedure, these people have different patterns of behavior and different patterns of boosting than people who are getting it tested because they feel really sick. And so I do think test negative designs need an asterisk next to it when it comes to COVID-19, because I don't think we know for sure that a test negative design is a very rigorous design and the exact measure of vaccine effectiveness is correct. And if anything, I do think you're onto something, that it's likely to overstate the benefit on that short-term endpoint than what would be the gold standard. What would be the gold standard? I think the gold standard would be somebody did a very large randomized trial of vaccinated college kids, randomize them to boost or no boost, and follow them for 6 months or a year and say, what's the difference in hospitalization? What's the difference in symptomatic SARS-CoV-2? And that will likely, I guess if I were betting, I'd bet there would be a short-term reduction in symptomatic SARS-CoV-2, but it would be a more modest effect than these test negative designs. But I think even if one were to concede that it does do that, it makes it less likely for you to have a cold or flu-like symptom in the short term. I think you have to ask yourself, is that enough to justify, I think, eroding someone's autonomy? And I think the answer is no. I mean, I don't think we have held that as a standard for time. And I think, how does that weigh against, I think, the real non-zero risk of side effects? And then the final question I have is that, and where is the evidence that other people are safer as a result of that policy? And I think that's a key thing, which is that when we move down this mandate route, I think that there is an obligation to show not just that there's an individual health benefit, I think that's part of it, you can't not have that, but that there's a benefit to other people as a result of me doing this, and that benefit is not outweighed by all the negative externalities of coercion. And what are those negative externalities? I think that we don't fully know, but some of them may be lack of faith in the institution, lack of compliance with other sorts of well-intentioned public health measures, erosion in confidence in other immunization protocols, and we see that even political backlash that leads to different policies that shape our nation in the years to come that may actually hurt health outcomes. So I don't think we fully understand the negative externalities. And so I guess for those reasons, I do think it is a bad policy decision, not well thought out.
I'll just keep following up. Okay. So so in the breakfast before this, we were talking a little bit about one of the reasons for, one of the more moral reasons for, overriding autonomy for the benefit of, protecting other individuals in the community. I recall the Daily Pennsylvanian actually wrote an article interviewing an immunocompromised student who was pretty, they wanted to have more or retention of certain COVID policies to keep them safe. And I think that's an interesting, consideration, but when it comes to, I'm just wondering, how do you balance values when it comes to the societal externalities, the decreases in, the negative externalities, as well as, the potential negative health impacts for young men and boys, and other things. How do you balance the ethics of that and the moral values that surround protecting people who are immunocompromised?
Yeah, I think that's a very important question. And as in my day job, and my pre-COVID job, and someday my post-COVID job, and my current day job, I'm a cancer doctor, and I would say many of my patients are severely immunocompromised, either by virtue of their disease or the treatments that we have deployed to treat their disease. And I think, like any doctor, I don't want anything bad to happen to any of my patients, and I worry about many of them. I lose sleep about some of them in terms of COVID-19 because it is a risk to them, even though they've been vaccinated. Even if they're getting some of these prophylactic antibody products like we're giving. So I guess the first things I would talk about this immunocompromised question when it comes to students or people in our lives who are immunocompromised, the first thing I want to say is reaffirm the importance of doing what's best for immunocompromised people. I think that's an important value. When I think about immunocompromised and COVID-19, I do think that one of the things we don't talk enough about is that there's a huge spectrum of risk. There are people who are getting certain types of chemotherapy treatments, who are undergoing certain types of medical procedures, who have certain medical conditions where the risk is enormously high, and I have a lot of those patients in my practice. And then there are people who really have other kinds of medical problems where they may feel like their risk is high, and it may be higher than the average person, but may not be as severely vulnerable as that most vulnerable person. So it is a huge spectrum. And I think we need to think about the policies might be different across the spectrum. And to be honest with you, at the extreme end of the spectrum, I advise my own patients to take extreme precautions. I wouldn't feel comfortable with some of my patients in a room of even boosted people because there's no assurance that some of them don't have COVID. Some of them may still have COVID. The next thing I want to talk about is, with the immunocompromised question, is there is short-term and transient immunocompromised status, and then there is permanent long-term immunocompromised status. I think you have to think about them differently. If you have somebody who's undergoing a procedure where they're going to be very vulnerable for a month, as I have many such patients, and they're severely vulnerable, the advice for such a person is it might be best to really kind of recuse yourself from society, have a family that kind of cuts itself off and get delivery for a month or two while you're in this extremely vulnerable state, and then afterwards you can take some liberties. When you have a permanent immunosuppression condition that's going to last year in and year out, I think patients and people will have to kind of make the choice of how do you balance living the life you want to live and taking appropriate precautions, knowing that that's going to be sort of a continuous decision you make going in and out for years to come. Because I think the reality is the virus is not going anywhere. We need to strike some balance for such people. Like, what are they going to do next winter? And the winter after that, and the winter after that. I think we need to work, and that's sort of an individualized discussion. The next thing I think that people have to think about more, inside the school and outside the school. Penn can do everything it wants inside the school, but my understanding is half your student body doesn't live on campus, and the city of Philadelphia just dropped mask mandates. And so Penn can do whatever it wants inside the class, but Penn doesn't control the universe. Penn doesn't control this. And so I think we need to be cognizant that all of us face risk in our, from coming to work, but we also face risk when we go home from work. And I also hear, as a related question, a faculty member who is extremely worried about getting sick in class from the students. But such a faculty member may also be going on vacations and traveling and doing all these other things. And so, whatever the policies are, there needs to be a thought across this whole universe of places we have interactions. And then the last thing I'd say is, what are the kind of personal precautions someone might wish to take for themselves, and what are precautions that we can ask others to take on behalf of them? And I think that's an interesting question. So personal precautions for an individual might be that person might wish to get 2 vaccines and a booster, and even a 4th vaccine. The FDA has EUA authorization for immunocompromised people for the 4th dose for certain types of immunocompromised status. That person may wish to also wear an N95, maybe with a one-way valve, because that will provide a high degree of filtration for that person if they wear it very perfectly. It will provide them a very high level of protection. In fact, when I go in a room with somebody active COVID-19, I can't guarantee that the patient will be in bed with the mask on, and the patient may be coughing in the room before I enter, and so I wear a tight-fitting sealed N95, and that provides me exquisite protection, I think. And we have a number of studies to show that in the healthcare setting. Now the question comes, what can we want other people to do to help to protect such a person? And I think the comment tacitly assumes that by having a booster mandate, and let's be honest, what will a booster mandate do? I suspect you may have already 80% of the Penn campus may already be boosted, just by choice. And it may be higher, 80, 90% may already be boosted by choice. And by having the mandate, you might increase it to 97%. You're unlikely to get it to 100%. And it may not even be 97, it may be 95, because more and more people may have some personal reason, health reason why they are not doing it, and there may be an acceptable reason submitted. Does that marginal difference, that 6% difference in boosting people with a booster that provides a transient reduction in symptomatic SARS-CoV-2, provide a sufficient benefit to a third party who's sitting in the room for some period of time to justify taking away the autonomy? And I think it's a stretch. I think it's very unlikely to be the case. I think, one, just medically, it is unlikely that the policy is even benefiting the other person. I think that's connecting all these dominoes together, where there's a lot of reasons of uncertainty along the way. And then second, is it sufficient enough to override someone's personal health choice? I think that's very shaky. So I think to this person, although I'm deeply sympathetic, I think that maybe that the energy on getting the other person boosted may be misdirected, that the energy should be on what they might want to do for themselves, and also kind of trying to think through the balance of how they want to live the next few years of their life, in the sense of what do they want to do and what are they unwilling to do, what risks are worth taking and what risks aren't worth taking. And I will say, having been a doctor for 7 years and attending and done a lot of work in immunocompromised populations, I will tell you that people are very different who are immunocompromised. And there are a lot of patients who I've done bone marrow transplant to, and immediately in the wake of a bone marrow transplant, they go to a toddler's birthday party. And this is back in influenza season. And that may not be something that's the choice everyone would make, but different people realize that we all balance these things, and for some patients, that's a risk they want to take because they want to go to that birthday party. That's what they're living for. And so I think people who are immunocompromised, we need to have a discussion, but I don't think that just by evoking those words, you have a trump card that means that you can impose, and then, whatever restriction you want on others. And then I guess that's the other question, which is, if it turns out the booster wears off after 4 months, can somebody realistically ask other people to boost 3 times a year to make themselves marginally better off? Or what if it's even more often? Or what if, can they ask, you to wear an N95 at all times, a tight-fitting N95, because that may further reduce the risk to them? Can they ask you to, not take that off at any time indoors, not to eat or drink for, and we're not just talking about this calendar year, we're talking about next year and the year after and the year after. So I think this is a tough balance, and how much you can realistically ask other people. It may feel as if it makes you safer, but what is the actual safety benefit to the third party, I think, is questionable.
One kind of follow-up that I have to that is, I think there's a bit of an issue right now that we're kind of conflating the terms comorbidity and immunocompromised in a lot of ways, and there's a question from the list, but it's something that I'm passionate about, which is, what kind of, how can we change attitudes about, or at least what role does, the university or any policymaking institution have in promoting wellness in a way to say that your ability to fight off certain illnesses and disease are going to be far stronger if you take some other precautionary measures other than simply boosting. So, this drug, this pill can only do so much if the rest of life doesn't reflect certain things. And so I think the challenge with that is, with anything, there's always going to be a bit of elitism, so you don't want to say, well, I don't eat X, Y, and Z, and you do, so therefore you should suffer greater restrictions than I do, or, whatever it may be. But I think that same narrative kind of applies with the booster, whereas I'm maybe struggling from this, and so therefore you need to be boosted. And so I don't know what role the university and other institutions have in promoting this idea of wellness and health and just overall illness prevention.
Yeah, that's a good point. I guess what I would say on that topic is that, when it comes to COVID-19 things you do, I think I put them in 3 buckets. One bucket is things you do that when you meet the virus, it's going to reduce your risk of bad outcomes. And I would say primary vaccination series for the vast majority of adults and boosting for older people are probably in that bucket. They do reduce the risk of bad outcomes when you meet the virus. The next bucket, I think, are things that delay the time until you meet the virus. And prior to the availability of vaccines in 2020, I did many of those things because it's extremely prudent to avoid meeting the virus until you've been vaccinated. I'd rather meet it on the back end than on the front end. My outcome's going to be a lot better. And some of those things might be, staying at home a lot of the time and not meeting people and, extreme sort of things. Those have a price, and the price is mental health, and the price is anxiety, and the price is potentially for some people weight gain. And I think there's some evidence to show that. Depression, that has a price, but you may choose to weigh that in your life. Wearing a cloth mask might or then let me come to the third bucket. The third bucket is things you do that might make it feel like you're delaying the time until meeting the virus, but actually doesn't do that much. And that might be where wearing a cloth mask falls. It's a feel-good thing, but it has at best likely very, very tiny effect size, probably no effect size. We have randomized data from Bangladesh on that question. And then there's some other things that people do that I think, from not opening the mail right away to this theater with hand sanitizer to temperature checks to closing playgrounds and swings and all these things we did along the way, that, not going to beaches. These are things that may have made people feel good for some time but didn't actually do anything. And I think when it comes to COVID-19, we forgot the first category, which is within there, I think, vaccination is the best thing you can do. But we could have also advised people to some degree to consider losing weight and consider sleeping better and consider kind of doing some wellness things. But back to your question about the university, which I think is a broader question, which is like, do universities have a role to, not to coerce you to diet and exercise, but do they have a role to advise you to like have healthy lifestyle habits? And I think the answer is it's not just about COVID, isn't it? It's just about the well-being of the population. That, if you advise Penn students to get out there and exercise, to go for a walk once a day, or do all the things that we think are promote healthy behavior. It might be good for reducing COVID risk very modestly. It might be good for their long-term longevity and cardiovascular benefit, and it might just be good for their short-term mental health because it feels good to get out and exercise and those kinds of things. So I think the answer to your question is beyond COVID. We can't just look through everything through COVID, and I think the answer is probably yeah. It makes sense for a university to kind of try to encourage its students to do things that improve their general well-being. And then I think that the other point I want to make to that statement about the boosting is, I think that the immunocompromised, we have to admit that some of these coercive policies and restrictions that we have all faced, particularly you have faced the brunt of as students, had a price, and that price was your mental health. And I think we have declines in mental health among a lot of people. And it is, to some degree, asking a deep sacrifice for younger people, particularly a young college person who's been vaccinated, to ask that such a person, as some college campuses are, to not leave their dorm room, or to eat alone, or eat with just one other person, or only take the mask off when they're alone with their roommate. That has a great, I think, price on what it means to be 20 and what it means to be going to this school and having this environment. And I think we have neglected and we trivialize that as if but that's to me that's emblematic of how mental health is trivialized. It shouldn't be. It's very important. And I think for a lot of people, it's the most important thing there is.
Yeah, as we go and start talking more into the public health side of things rather than the acute sort of medical details, I think that one thing I've learned through the past couple of years is something I sort of learned in a social studies class about people say there's a political spectrum and it's a line. And you could argue that in public health, there's a spectrum of individual liberties to public health, and that's a line. But my teacher in 10th grade, the social studies teacher, he argued it's not a political spectrum, it's more of a political circle or a curve. And I think we've seen that it's kind of a curve in terms of public health. You think when you sacrifice sort of individual liberties, or maybe everybody individually is making sacrifices, becoming maybe a little bit less mentally healthy, something like that, for the greater good of the public health, then you estimate that there'll be an increase in the overall public health. But I think we've seen as we think we're just going to run a straight line where we decrease individuals and then that'll increase public health, we've actually seen that eventually when you think when you go far enough, you think you're increasing the public health, but since you've actually decreased individuals' mental states, in many cases just individual liberties as well, which is going to be a contributing factor, then you see a decrease in the public health consequentially, because when you add all of those individuals up, you're not getting the addition and the overall result that you want. So where do you think kind of that inflection point is, and where did we cross it, and how do we get back to where we need to be?
Yeah, I mean, I guess I would say the first point is that when you think about the society's health, it has to be holistic. We can't have a myopic view of COVID only, because it has to be COVID alongside all the other things that are important in life. Heart disease, cancer, weight, diabetes, all the challenges, depression, anxiety, all these things. So we have to look very holistically. And then the other thing I want to say is that it will be another decade or more to know the full impact of our policies throughout this pandemic. But I'm not persuaded that all of them were in the best interest of even COVID-19 health alone or total health. And I'll give some examples. In a 2-week span in March of 2020, the globe pretty much essentially cut all travel and asked people to shelter in place. Truly unprecedented action. Some places that may have provided some benefit. It might have been the right medicine at the right time for some places that would have otherwise faced an epidemic spread then. We're able to not have that happen and then able to sort of wait it out until vaccines were available in November or actually December of that year. So it might have helped some places. But other places, it may have had terrible consequences. Some places where that might have happened were a place where there was real no person-to-person transmission at the time of lockdown. Lockdown hard in March of 2020. And they locked down for 4 weeks or 5 weeks or 6 weeks. And then they opened up again in the summer because they'd just been 6 weeks in their house. Nobody in that town very few people got sick in that area. And then by the time the epidemic wave hit in September, October, November, as it hit the Dakotas, the political will and appetite to implement any restriction was altogether gone. So you can give a medicine at the wrong time, lockdown potentially, and actually make it impossible to get buy-in from the populace to do it again. And that might have actually led to worse outcomes. The other ways it leads to bad outcomes are, I think school closure was a great example, because you took away something that is, I think, the last tattered rope ladder of upward opportunity in this country. We have stripped away so many of the things, but the last tattered ladder is a public education. And you took that away from kids. You took it away for a long period of time, for 18 months in some cities. You didn't take it away equally. Right of center places actually were much more likely to be open than left of center places. Places with weaker teachers unions were more likely to be open than places with stricter teachers unions. There's no correlation between the school opening and the cases, the hospitalizations, and the deaths, but there is correlation between political valence and union strength. And that to me is problematic. That means we're not treating COVID-19, we're treating sort of all the petty politics that enter into life. And I think ultimately there are a number of studies that show that by closing schools, you make either no change at all in community transmission, that's a German study, or a very, very modest reduction in community transmission as a result of that. And that's a study by the University of Southern California investigators. But what you lose is you lose a generation of kids potentially who are not falling behind on education, who are not going to graduate, who may have higher rates of violence and in their lives as a result of these choices. And very likely their longevity will be shortened as a result of the school closure. I mean, I have no doubt that as time goes on, we will see accumulating harms of that. So how do you weigh that into the policy? You had availability bias. You felt and you saw the COVID cases. That was all consuming in your mind, but you didn't see the kids who were not graduating, who are being neglected, et cetera. I think that's a place where we're going to see that our policies were grievously in error, that there's a net public health deficit. And then I think the vaccination question comes in. Mandating vaccines, mandating boosters. I certainly think the case for boosting young, healthy people in college universities is absolutely one of the weakest cases I've seen in this whole pandemic. I mean, I think that just doesn't have a case to use coercion in that space. Now, I was even a little bit cautious about mandating vaccines at all. Not because I don't think they're of huge value. I do think they are. But I worry about mandates in this country at this time. And we can talk about some of these other analogies, but this is not 1965. This is 2020. America is deeply polarized. And there are a lot of people who don't like being pushed around, and they feel as if they've been neglected politically. And so I was speculating even in the summer that when you implement mandates, yes, I guarantee you're going to change sort of marginally a fraction of people are going to be vaccinated. There's going to be, vaccines were on an upward trajectory. Some people like to take credit for the moment they issue the mandate, every additional vaccine is credited to the mandate. That's not true. It's already on an arc. It has a certain, if you did nothing, it's going to keep going up because some people are going to come around to doing it finally. It's about the change in the arc. What was the change in the arc? And I speculate that it is a modest, like across the whole population, maybe we're talking about between 1% and 5% change. All this draconian effort has increased it that much, which is modest. And you may gain something from that. There's somebody out there alive as a result of being coercively pressured to get the primary series, I'm sure. I'm sure there's somebody, like a 50-year-old person, 60-year-old person who otherwise would have had a bad outcome. That's good. But it's offset by a lot of things. It's offset by that fraction of people who are pushed out of workforces. Those people are kind of pushed out of society. Some of those people, I think we can say, are treated unfairly. Imagine a nurse who worked in the first waves and actually got COVID while taking care of people, and then that nurse was fired as a result of not complying. I think that's a cruel policy, and that's sort of not the kind of thank you that person should be getting. I also think that there's second order effects on the mandate, and the second order effects on what are the effects on other childhood immunization practices, and then what are the effects on politics and political stability and what people think. And if people, vote for different people, if people think differently, if people have a backlash politically, those are negative health consequences that stemmed from that action and should be attributed to that action. And so when I see people who are, they're quick to tally the scoreboard and say, we got to win, the percentage is higher, they're only looking at the endpoints that they think are affected by their policy, not all the endpoints, and they're not tabulating all those things, and they're not looking long enough. And so I think, we should be careful to know, because the premise of your question is that a little coercion is good, but a lot get into trouble. And the answer is, I guess, I'm very unclear which of our policies had a net benefit and which ones actually had a decrement towards our health outcomes and our political stability. And then I guess that's, yeah.
Yeah, I mean, I just think that for that perspective as well, that I can't think of a single thing in this world where a one-size-fits-all policy is the solution. Like, I can't think of one. And I mean, yeah, so I think this idea of just a blanket policy across everyone kind of takes the burden off of the individuals imposing that, to actually take the time to say, what is the best policy for these discrete groups? And even then, coercion is still a whole separate issue, but at least determining, what's the burden of proof to actually say, this is what we think should be done.
I guess I'd say policy is always hard. And throughout history, I think there are many well-intentioned policies that actually did more harm than good. And some of the things that make it even harder are you have a population of people that is anxious and afraid and therefore may not be as rational as they would be in different times. You have an uncertain situation where the uncertainty bounds of our decisions are massive, where you have second order and third order and fourth order and 40th order effects, spillover effects you never even saw coming. And you have a shifting enemy, a shifting target, a shifting virus, And so I think that, and this has been conceded by the CDC director recently in an interview, that when they implemented vaccine mandates, they didn't see Omicron coming. They didn't realize that there could be a variant that pierces vaccine effectiveness, as has happened. But I think that variant, the moment they saw that, that's a key difference, because the prerequisite to those policies was that it's not just a personal health benefit, it's also a benefit to other people in halting transmission. If it was just about personal health benefits, then could we compel you, if you have high blood pressure, to take your blood pressure pills? Could I literally come and have you supervised take it? Because it'll be better for you. And that actually, I have very high confidence that it would be. I have randomized trials with survival benefits. I know that to be true. And so should I come to your house, directly observed hypertension therapy? I mean, we could start talking about those kinds of things. If the threshold is just individual health benefit, I think the threshold for a medicine that you ingest or a medicine, drug product you take, particularly a product that's under auspices of emergency authorization and that's come out with, really rapid approval, that threshold is not just a personal health benefit, but a benefit to others. And I think across these questions, people have been perhaps dishonest to some degree about the residual uncertainty. This immunocompromised person's question, I think the dishonesty is that we don't know. I mean, I just don't know that if I make Penn's booster compliance rate go from 80 to 87%, that it's going to be safer for this person. And I don't know that with any confidence, and I highly doubt that that's the case, actually, if one thinks about the universe of interactions this person's going to have. And Penn is just a tiny part of their life. And so for that to override somebody else's autonomy, I think, is a tall order.
I have a quick question, because it's kind of been broached a little bit, about the profit motive in relation to healthcare in the United States, and also the influence of money on political apparatus that exists. Both Democrats and Republicans are reliant upon, dark money and money that's associated, and we see Pfizer and Moderna raking in record profits, billions of dollars. Could you speak on the unintended consequences of that reality, especially as a healthcare practitioner yourself, and what should be done or how that should be handled in the future?
That's a great question. I guess I would say that I think there's sort of a middle ground here between the kinds of arguments I hear, and that is, I actually do think, as much of a critic of the pharmaceutical industry I've been for a decade now or longer, I do think it's important to have a profit motive in healthcare. The profit motivates people, I think, to innovate, motivates people to work hard, motivates a lot of good things in society. What you want to do is have regulation that makes sure that the profit motive and what's in the best interest of people are hand in glove. They line up. And I think if we're perfectly honest, what's in the best interest of people and the profit motive, they have some overlapping vector. I mean, there's some, like if you make people better off, you can make money. But they're not perfectly aligned in the system. They're slightly misaligned. And they're slightly misaligned because it's a lot of lobbying that goes into it, trying to make it a little easier to get profitable. And that's not always what it means to show someone's better off. And so when I think about the vaccines, I do think that the development of the mRNA vaccines was the greatest, I think, medical accomplishment of the last few years. And it is remarkably life-saving. Those first 2 doses, particularly for older people, massive benefit, clearly remarkable. But then I think about what will be the threshold for us to be on the perpetual booster train. And I think that the company's interest is to have the lowest regulatory hurdle to give people a yearly or bi-yearly or even quarter, I don't know how much they want to do it, but the company wants a very low regulatory standard to do that. Why? Because that will ensure that they will make a lot of money for years to come and guarantee a certain market share. But the public health question should be not necessarily that, like, we'll never give you a yearly booster. Maybe that is right, but prove to me that by giving a yearly booster, you're making everyone better off. Prove to me that you achieve that, and then I'm happy to concede to you the money and profit, if that's the case. But I think that that's the problem that you're getting at, the lobbying, and then the political contributions, and these kinds of things where the company wants to influence the regulators and the policymakers, and then the White House, to set a lower standard for these kinds of policies. And so I think the boosters is a great example. It's unprecedented. You had 2 senior people resign. These aren't people who worked there a week or a month. They're people who worked there decades in vaccine products. They're people who didn't even resign under the last guy. Supposedly the last guy was pressuring them very hard to approve a vaccine prior to the election so he could have a chance at re-election. And they didn't resign under him. And they resigned under this administration. That must tell you something about the pressure they're under and how they feel that they themselves are coerced into authorizing a booster. And they've written a number of op-eds in the Washington Post, et cetera, being critical of universal boosting, particularly in your age group. And so I think one has to wonder that why do we even have the FDA? We have the FDA because we don't like the idea that it would be a direct political appointee making vaccine products decisions. That's a very unpalatable idea. We want somebody with expertise in vaccine products, been there a long time, who doesn't have a political angle to this, is willing to approve things no matter who the president is and no matter what the political fortunes of those decisions may be. But politicians and public health people, they have divergent interests. I mean, a politician, particularly a politician who's facing a midterm election or an election, they may have a perverse incentive to get COVID numbers down no matter what it takes, even if those are things that have other negative externalities that don't get counted on the scoreboard, like, all these other things that we talk about. And so I think they're not the right people for the job. And so I do think it's problematic. That doesn't mean we should dismiss everything. I think that the vaccines are great, but it does mean we should be skeptical of this idea of having a perpetual booster.
I want to come back to that question of sort of the vaccines and also this question of political legitimacy in relationship to them, because I think for people like myself who are, in the humanities or outside of this kind of medical or policy world, one of the most concerning things is the fact that there hasn't really been any transparency about these products or the justification for imposing them. So, with the original vaccine mandate as well as the booster mandate at Penn, I personally am not aware of any evidence they've really provided as to why these policies are required. And then, just recently, after a FOIA request, these Pfizer documents have come out, that have actually provided what I think would be useful data for doctors who are doing individualized medicine for their patients about certain vaccine safety risks. And the fact that that had to be sort of extracted via court order can oftentimes be very disconcerting to people who already have a distrust in these institutions, be they political or pharmaceutical. And I think alongside that, this has been brewing, I think, in the United States for a while, but there's just a growing distrust in the scientific establishment in general. And it felt like COVID for a lot of powerful actors has been sort of an excuse for implementing these vastly reshaping policies, putting people online in front of screens all the time. There's talk about fourth industrial revolution as the new age that we're in, where everything is sort of determined by machine learning and AI technology. And then, of course, in the private sector, we have things like the metaverse, where everything could potentially be this, virtual fantasy land controlled by big tech. And I think for a lot of people, you mentioned about sort of the suspension of certain aspects of rationality when it comes to these emergency scenarios. I think there's been a difficulty in communicating how certain scientific or public health interventions might be justified and certain ones that might not be justified. So I'm just wondering how you feel like the sort of science and medicine and public health community can really recover from this, because I feel like it's been a huge blow. And, I myself am definitely less trusting of these actors than I was before the pandemic, and I didn't have a whole lot of trust in them then either. So, I think what you mentioned about there being long-lasting effects of some of these policies, especially when it comes to political division and fragmentation, I'm just wondering how you think that can be mitigated, if it even can at this point, by people in some of these positions in science and public health.
Well, it's a great question. I guess I echo a lot of those points, and then I'll come to the core question. I guess one of the things you mentioned was vaccine safety and FOIA documents and these kinds of things. And I guess I'd say that just as it's difficult to know, is boosting a 20-year-old provide an additional reduction in hospitalization, it's also sometimes very difficult to know which side effects are attributable to the vaccine and which just happen to happen after the vaccine. And sometimes if you get reams of data, you still know closer to the truth, because you really need sort of to know what happened to a group that was vaccinated, a group that's otherwise similar that wasn't, and subtract the two, subtract one from the other. And you don't always have that. And I think so that's one real challenge when it comes to that. And you also need a huge sample size, a lot of people. And then when you start to look in the real world, the people who have rushed out to get vaccinated and the people who took their time, they're not the same kinds of people. And so some of these things are confounded by that. So I guess I want to be very clear that I think that not everything people think is attributable as a safety signal is actually a safety signal. The next point about the technology led to this response. I think you make a very astute point, which is that had it not been for the technology in place, and I think we were talking about this before we started, in 2020, we wouldn't have had this particular pandemic response. If there was no Zoom or Uber Eats or Amazon Prime or Netflix, I think it was very unlikely that you would get such a large fraction of people to stay at home for so long. You would have had widespread layoffs, I think, in the upper middle class sector in a lot of companies if people weren't to come to work for 8 months plus, and that would have been untenable. And I think we would have found some way to make it work. We would have ventilated offices. You go Monday, Wednesday, Friday. I go Tuesday, Thursday. We're alternating schedules, something to kind of find some balance in terms of working, living, but also taking some precaution. And I think that would have been good in a lot of ways, actually, because it would have been good for everyone's mental health, and it would have made it easier off-ramps, because a lot of what we're talking about is there are no off-ramps to this because we are still consumed by the anxiety. That anxiety that was only relieved by staying at home all the time and ordering food. Forget about the people making the food, but ordering the food, I think, that was a deficit, I think so. But if upper middle class or richer people had to find some balance, I think we would all be much more relaxed about peeling away some of these restrictions and going back to normal after vaccination. Okay, then your last point is how can the trust recover? I think it has been a catastrophic blow to trust in science. And I think that people are underestimating what has happened to their credibility and trust. In the broader American public, we are all ensconced in academic institutions, myself included. The majority of people I talk to are professors. I'm talking to a certain crowd of people as a general rule. And those people, I think, are largely shielded from the reality of how much distrust there is in the enterprise of public health. Things that I think, I do worry if it can even be salvaged. I sometimes worry that science may even tear in two. I think the worst thing for science would be if each political party has their own scientific branch. If each party has their own set of scientific principles, that would be the death of science, because science is not politically driven. But I worry that we risk leading to that scenario. And why is that happening? And I think there's a core reason why that's happening, because people are not honest about uncertainty. Science is about two things. One, science is a method of understanding the universe, but that's what science is. But in order to do science well, you have to be honest when you don't know the answer. And I think some of the questions you've asked, if we're perfectly honest, we don't know the answer. I do not know the answer if you getting boosted will further improve your health beyond 2 doses. I certainly don't know the answer if you had 2 doses and an Omicron infection. I just don't know the answer. And yet you hear rhetoric from public health experts that it is in your best interest. We know that with confidence. That's an uncertain claim. They shouldn't say something that is certain that's uncertain. Now, acknowledging uncertainty is the first prerequisite, because if you don't even acknowledge it, you will never even think about ways to reduce it. There are things we could do to answer so many important questions. For instance, right now, what are some of the most divisive issues I see? I see the New York City mayor peeling back mask mandates, but keeping them in place for 2 through 4-year-olds. That's a divisive issue. It's politically divisive. It divides, I think, parents who feel differently. Some people love it because they think it protects their unvaccinated 4-year-old. Other parents are furious by it because they think it is an imposition on a child with the lowest risk. Now, what might, if science were honest, and what's the honest answer? The honest answer is that I don't know if a cloth mask mandate in a 4-year-old provides a health benefit. I guess we could do a study. And the study could be, we have a bunch of daycares in New York City that become optional, parent choice, and some where it's mandatory. And then just follow for case counts, and we'll have an answer within a month if they did it in New York City. But nobody wants to admit uncertainty. And instead, what you see is both the mayor and his political opponents will find some scientist to say, we should do it or we shouldn't do it. And that further fragments science. And so I guess I would say that I really struggle to know if it can heal. I think there are a lot of reasons why people would rather have propaganda than true science. True science is admitting that a lot of these questions are very uncertain. And then the last point, since the focus of this is really on boosters, I think we have allowed Pfizer and Moderna, who developed great products, yes, but we've allowed them to capitalize on that to the tune of $70 to $80 billion from from this product. That's a healthy return on their outlay. That's very healthy, considering all the subsidies along the way. Now, what I would say is that they have enough capital. That's one, check. There's plenty of people with different clinical scenarios. There are people who have gotten 1 dose and had a breakthrough. There are people who had 2 breakthroughs and 2 doses. There's so many different scenarios that we could be doing kind of unique studies for each of these people who have faced these questions. Pfizer could be tasked with doing that as part of their commitments. They have some commitments, post-marketing commitments, but they could be tasked with more commitments. But why don't we do that? And I think to some degree it's the answer to your question, because there's heavy lobbying pressure not to do that and just to assume the answer is more is better. And I think to some degree it's your trust question, which is that I think many of the issues that have been most polarizing would not have been that way had we done a study. For instance, had we done, masking is deeply polarized, boosters are deeply polarized. I think the decision that in the next month or 2, we may see a vaccine for 6 months to 4-year-olds. I think that's going to be polarized. The primary endpoint of that study is antibody titers. That's a tough endpoint. What does that mean? If the primary endpoint of that study was how many kids in that age group are hospitalized, and it was a huge study, I think 2 things. One, it would have enrolled very quickly because there's so many parents very eager to get their kid vaccinated. It would have you can enroll 1 million people in a week in this country because that's how many parents are really wanted to get their kid vaccinated right away. And then 2, you can answer the question rigorously, and then answering that question rigorously will actually prevent skeptics from saying anything. What can a skeptic say? We have proven. And if they had proven boosting 20-year-olds was beyond a benefit of the doubt, Paul Offit would support it. And I think you all wouldn't feel so strong. You'd be convinced. You wouldn't need to be coerced. You'd be persuaded.
So one thing, I appreciate you coming to talk about all these things, and one of the great things about conversation is shining light on many different things and thinking, because the world's very complicated and you can't really understand. You can guess what is going on and make assumptions, but when you shine light on it and piece it out and think about it, it really can help us gather more data to make better decisions. And I thought in a conversation I had with one of my classmates, we talked a bit about, 2020, right? We didn't know much, but decisions had to be made. And they were asking me, what did you think of, do you think that, certain decisions shouldn't have been made? Should there have not been any decision made until we had the data and so on? And And for me, I said, I'm not sure. I'm not a policymaker where I have to face hard decisions, without knowing what exactly could happen. I could try to weigh the cost benefits, project out into the future, but still, I think the most responsible thing is to make a decision. But that's not what I have a problem with. My problem is when a decision is kept and there's no effort. There's no effort to revisit the decision. There's no effort to, collect more data. There's no effort to, figure out, like, for example, when it comes to talking about these things, I realize that people only focus on the benefits and never the costs. Kind of having a halfway, like, let me put a blinder on what is happening because of my decision. I'm only going to focus on the good things. I just wanted to kind of shine a light on that. But that I'm going to then ask you an unrelated, somewhat related question, which is I've been also talking to other classmates, and in my own experience, I'm a PhD student, and I'm going to be looking for postdocs soon. And some postdoc positions, post-PhD positions, they have their applications out. They're calling for applications, and they list a set of requirements. Must have a PhD in neuroscience. Must have all these things. And then some. Now I'm noticing they have a requirement for vaccination as part of a requirement for employment, and that made me think, well, what is Penn going to do with students in the future? Are they going to require vaccination for enrollment? And my concern is not necessarily like the world is changing, the US is changing their policy in terms of like allowing people to go into restaurants and in concert venues and things like that, with or without masks, with or without showing the vaccine requirements and ID. But I'm scared because I feel like there's going to be a silent schism or requirement or like stratification in our society where in order to get certain kinds of jobs that are affiliated with, a certain class position, they're going to require a vaccine as something that you need in order to be enrolled in particular schools or be employed. And I think that is very problematic. I just wanted to know if you've thought about this particular dynamic, and I'm just hoping that, this doesn't just get pushed under the rug as, ever since COVID, you always needed to get a vaccine in order to get a job at a law firm or go to any of the Ivy League schools, you need a vaccine. I'm concerned about that.
Oh, that's a great question. Okay, I guess just one comment on the first part of your thing, which was like, did you just want us to do nothing? I guess I'd say the answer to that is, I think one of the things people underestimate is that what was the change because of your policy? What was the incremental difference because of your policy? Now, even if there were no policies like shelter in place or lockdown or business close or et cetera, you would see dramatic reductions in mobility. Because when people are scared, people are going to change their behavior voluntarily. And so the policy leads to I think people overestimate the difference the policy led to. The policy may be extremely marginal in terms of actual behavioral change. The behavioral change was going to happen no matter what. When cases go up, behavior changes in advance. And when cases start to go up less fast, the second derivative changes directions, then people's behavior changes already. They start booking travel. So I think we overestimate what the policy does compared to people's voluntary thing. The second thing I'd say is that there was at least some questions. There was an outlier. Sweden never closed primary school. How did we treat Sweden? Did we treat Sweden as a thoughtful actor which has for 20 years invested more, or for 50 years invested more in its children than any other, than most peer nations, much more than our nation? No, we didn't. We treated them like a pariah, Like they wanted kids to die. They were demonized. I mean, the newspapers, when they stopped talking about Sweden, I knew things must have been going well in Sweden because there was the whipping, all they did was, punish Sweden in the news. That to me is problematic. There was much more uncertainty. And now I think they've been largely vindicated in that choice. And then the third thing is evidence generation. Yes, you can act, but do you have to not collect evidence along the way? We didn't do any systematic seroprevalence in the spring of 2020. We had no idea what the pandemic was doing. And we didn't do randomized trials of masking or social distancing or hand sanitizer or plexiglass face shields or 3 feet versus 6 feet. They pulled out 6 feet from nowhere. We didn't do studies of all these things we could have done to learn something along the way, not just for this pandemic, but the next pandemic. We could have done studies on different thresholds for reopening schools, different quarantine policies. We did zero studies. What justifies that? Yes, you have to act, but you can act and do the study on the side, so at least then you can change. But that speaks to your second point, which is course correction. If you don't have a system in place to generate evidence, you'll never course correct because you've already committed to doing it. You just become more stubborn and in your ways. The point you're making, I think, the second point is this: will vaccines be and receipt of vaccines be a threshold for societal decisions or societal roles, like being a lawyer or being a doctor? And I guess what I'd say is a few things that I think. A few things I think. One, I hope that as we get further away from the acute hospitals overcrowded situation and people can get a little bit less anxious about COVID-19, I hope we start to see things clearly. And one of those things I think is that even though we have vaccination, can we say with confidence that we have optimized vaccination? And the answer is I don't know. I think that there are ways it could be better for people in our demographic and age group. I think, why are we doing 21 and 28 days? Can they be further apart? For kids, 5 to 11, I think right now we have vaccine effectiveness that's very, very low. And the question is, did they get the right dose? And the dose was really kind of picked in a very quick way. Is there dose optimization there? For a man who's 25, do they always need the second dose? For a boy who's 12, what should the dose be? There's all these questions about how to optimize this. Once you know that vaccines are beneficial, you're not wedded to this schedule and this dose and this, and that needs to be sorted out. Okay, that's part of the question. And then the next thing I think is that people who are policymakers need to ask themselves, what does the policy serve? Now, having gotten a vaccine is a marker of a lot of things, but one of the things it is a marker of is class, political valence. It's a marker of virtue and signaling the virtue to others. And I think we should be very careful that we're not having the policy to signal the virtue. We're having the policy because we actually think it makes the person better off and makes other people better off. And I think that has to be readdressed as we go forward, because I think what you will have happen, as with lots of epidemics throughout human history, the epidemic will eventually saturate the entire population. We will all likely have breakthrough in the next 5 years, probably. It will get very high 90% of people will have had a breakthrough. And then COVID-19 will be a disease of childhood. It'll be a disease that people contract early in their lives when they first meet it. Some of those kids might be vaccinated. If there's a policy that mandates vaccines at 6 months old, then maybe all of those kids in the US will be vaccinated. But globally, I don't think they'll all be vaccinated. Many kids will meet it. I think those kids who meet it, if they're over the age of 1 at least, 1 to 4, they'll have incredibly good outcomes with COVID-19, and they'll clear it in their infancy. And then someday, 50 years from now, COVID-19 will be one of the several, not many, but several circulating coronaviruses. And in that case, will we still have the policy that to work it as a lawyer, you have to get the vaccine? Or will we finally be able to say, if not, then the child had it and cleared it, And so I think that should be revisited constantly, often. And I think that we have to be very careful that you're not enforcing something to signal and to be classist. And that comes back to the question of colleges, I think, the core question, which is how much of what colleges are doing is to actually make people better off, and how much is it to signal to others that we're taking this seriously? And we have to be very careful that we're not doing it for that reason, because that's not the reason why you give medical products to people. You have to do it because you really have some confidence it's in people's best interest. And I worry that they've confused that. And then the last thing I would say on this issue, at least the colleges issue, this is one of the points that we were talking about with Bill. I mean, people making these decisions are well-intentioned, but to some degree, colleges and all sorts of businesses have become administrative states, where you have administrators who seek to balance so many interests. And I sometimes worry that that's not the same as having somebody in charge who is really tasked with just the greater health of the community. That administrators have thoughts beyond just pure health. And I think that can lead to some perverse things, like this situation you're talking about, where we could be 20 years in the future and you're denied entrance at a law firm because you missed a booster in 2024 or something. I think that would be an absurd situation.
I just want to see, I think we might have a question on the live stream.
We do, and there was some perfect foreshadowing for this in the last question. So if, in your estimation, what percentage of the population has contracted COVID? And if that number is very high, say like approaching 100%, doesn't that necessarily imply that we've already passed the peak risk? Like, so long as there's not a more dangerous variant that emerges, everyone has some sort of immunity.
I guess I'd say the answer to the question, based on CDC data as of a week and a half ago, is they estimate 140 million Americans have had COVID-19. And then you pair that with 200 plus million Americans have had at least one dose of the vaccine. And there's some overlap Venn diagram there that's kind of opaque a little bit. I think exactly how much it overlaps, I don't know the exact answer. But I guess the answer to your question is yes and no. Do I believe we're past the worst of it, i.e., the number of people who will die because of COVID-19 in subsequent waves will be less than prior? I think that probably will be true, like that we're past the worst of it. I'm hopeful, and I think that that's probably the case because of natural immunity and vaccination. But do I think the number of cases will be lower going forward? And the answer is I don't know. Cases, of course, is a product of, I guess for a few reasons. One, I think we are learning that if you had COVID before, you can get COVID again. If you had COVID in the vaccine, you can get a breakthrough COVID. And if you have widespread availability of testing, and we finally have gotten to the point where I think testing is no longer supply constrained, you're going to get people testing a lot. And so very likely, I don't know when it will happen, maybe 2 months from now, 1 month from now, 5 months from now, or the winter, there's going to be a spike in cases. And the spike in cases may be higher than any spike that has ever happened to date, because there's going to be lots of breakthroughs and there are going to be people testing more than they've ever tested before. And I think when it comes to societal perception of COVID-19, it's not always the hospitalizations and deaths that drive it, it's also the cases. And so if cases explode and we have more than 1 million diagnoses a day, I think people will be very concerned. And thus they will want to re-implement, I think, many restrictions, certainly masking, but maybe even others. Distancing and school closure, I hope not, but they might want to. So I guess I think I worry about that, But in terms of a strictly medical standpoint, like, do I think that we are through the worst of the number of people who will be harmed from the virus in a unit of time? I think the answer is yes, thankfully. But I do think that this other challenge exists because the pandemic is also how people respond to the pandemic. And a corollary, if many businesses set policies that if you test positive, you got to wait a long time before you can come back to work, even if you feel better, which is not the policy we had for many years. If you had a cold or flu, and the moment you felt better, you could go back to work. There was no testing, for all these years. But this is one thing where we may have some testing policies around going back to work. If you have a lot of cases in a short period of time, you can really crush some sectors of production. You can have shortages and things like that. And so I do worry that it may not be the virus itself doing that, but our policies built around it that were well-intentioned may lead to some challenges. I don't know that this will happen. I think anyone who thinks about the future here it's always speculatory. But I guess we don't have a reason to think that that you are totally immune from getting some mild breakthrough. We are likely all still vulnerable for that. That's possible.
Yeah, I think the case counts are like what I worry about as well in terms of being used as justification for future restrictions and things like that. I don't know if we've already addressed this, but in terms of say COVID doesn't just become a disease, like a milder disease of childhood, like a chicken pox or something like that, and we have variants that pop up every once in a while, similar to the Alpha variant, that have a lot of morbidity associated with them. I don't know if we've already addressed this, but when would you find it acceptable to have that on a vaccine schedule to enter public schools or universities? Obviously, you'd probably want full authorization, not just emergency use. And then what other criteria in terms of trials and just sheer length of time in terms of testing of the vaccine would you and a lot of public health medical experts typically want to see before something gets put on vaccine schedules en masse?
I guess I'd say that I think it's going to be debated. As you know, in California right now, the governor has basically said that once the vaccines for 12 and up get biological licensing agreement or the full authorization, not just EUA, it will be mandated as a prerequisite to go to public school. That will be the cudgel used in California, and there's a pending bill that will mandate it as of January 1st, 2023, if this bill goes through, for 5 and up under the auspices of EUA as a prerequisite to go to public school. I find that problematic in a number of ways. One would be the simple problem, which is that you will throw some kids out of school. And you're not going to throw kids out equally across socioeconomic and racial categories. You're going to throw people out more who are already marginalized and disadvantaged, because those are the communities that have less vaccine uptake. And by doing so, you will perpetuate, I think, some of the deepest entrenched inequities in the society, and it will be the price you pay will be very steep. So I think that California bill is a very bad idea. I imagine the person who wrote it is not ill-intentioned. The person actually thinks they're making the world a better place, but I think the person doesn't see what will come. Los Angeles almost implemented a mandate for 12 and up, but then at the precipice of doing it, they realized that 40,000 kids are going to get thrown out of school. They've not released the socioeconomic and racial demographics, but I think they know what they are, and they hesitated and they didn't enforce it at the last minute because they didn't want, they didn't want to do that. I think, thankfully, I think that if there are more vendors in the digital Zoom school space, it will actually incentivize them to have more stricter policies, because then they can get the benefit of having supplying the vendor of the Zoom school. But your answer to like what it takes to be on the schedule, the routine schedule, I think it's a complicated question. I think different people have different ideas. And I don't think that there's going to be a single idea. I think states will have different rules. I think that they will tie it to the one thing that has been used as a way to get vaccination rates up, which is public education. I think they should be careful, because, I think there's the medical things. What do you want to see? And what do you want to see? I think you want to see a safe vaccine. You want to see an effective vaccine. You want to see that the dose, you've tried different slight variability in dosing, and you make sure that this is the right dose and the right schedule. I think that's what you want to see medically, so you can go and say, we have some high degree of confidence that this dose in this age group will provide this reduction in reduction in severe disease. That's why you ought to do it for your kid. I think that's what you want to see medically. But then sociopolitically, I think we're in a very different time. It's taken on sort of different dimensions. You want to be very careful that you're not throwing out kids out of school, for a disease that is a threat to children. It is a threat, but it's possible that throwing them out of school is a greater threat to their health and well-being. And so you have to be very careful that you don't harm them much more. And to be honest, they've already been harmed. They have faced the greatest harms of the pandemic, because it's easy for policymakers to take away things from children, because children don't vote. And I don't think there's any group that's really represented their interests in the United States. And that makes me, I feel sad about that. So I guess I would say that I would tread very lightly if I was the policymaker. That even if I had the clear medical evidence, I don't think I would always enact the mandate right away. I'd go slow. I'd try to bring people around the gentle way. And I think that goes to his point about trust. I think that the last thing you want to do to a group of people that is feeling distrustful is to use brute force and coercion on their children. I think what you want to do is get them to see it the way you see it, which is the tough part. It's actually, kind of the challenge of being a doctor, is that you do that with somebody one-on-one, and you have to build a relationship. So I do worry about that. And I really worry that we live in a moment, the last point is that, this is related to some things that you all were talking about, social media and about the kind of feedback you've gotten, is that I do worry that we're at a bad place where people confuse signaling and being a part of the right group for having a thoughtful consideration of policy. Now, from talking to you all, I know, you all are concerned with the well-being of everybody. You're deeply sympathetic to immunocompromised people and children. And you're also trying to balance that with, what kind of protection should we give individuals for making healthcare choices that are right for them. But it's easy, I think, in this modern environment for people to demonize the opponent and to say that they don't care about those things. And it's easy for people to get caught up in the zeitgeist and want to mandate things because it makes us feel powerful and strong and that we're doing the right thing. But I think we have to be very careful that we actually are. And it's very likely that these things will backfire. So I would be the last thing I would do is put another wall. The last thing I'd say is, we should not forget, there's still, hundreds of thousands of children that are missing. Nobody knows where they are. They've been lost from the pandemic and they're not going to school right now. I would want to find them all and bring them back to school before I start any mandates, until I find me every single one of those kids. I don't know where they are. I think that's a huge policy failure. And so before I try to think of walls to put up around the school, I need to get those kids in school.
Does anybody have any more pressing questions? We're nearing noon right now.
Could you touch very quickly on therapeutics?
Yeah, I guess I'd say that therapeutics was, there's so many parts to it to talk about, but I guess I would say that in some degrees it was a strength of the pandemic, that although we didn't run many trials of non-pharmacologic interventions, or these NPIs that I talked about, we did do many trials of therapeutics. The United Kingdom did some even better than us. They had the recovery trial, which is many arms. And what have we learned? I think we've learned that, there's a spectrum of disease of COVID-19 from you are somebody who's immunocompromised but have never encountered the virus and you receive an antibody to prevent you from getting it if you were to meet it, to you met somebody with the virus and you might think about taking a medicine to decrease the likelihood you get sick with it, to you're mildly ill. Is there a medicine that can help you getting hospitalized? And this is where this Pfizer product is. People think it has a role, this Paxlovid. To you're hospitalized, but you're not on oxygen. What medicines might you consider? Or you're hospitalized and you are on oxygen, you're hospitalized, you're on mechanical ventilator. What medicines might you think? And there are many, many studies along this spectrum. And we have learned a lot. And there's some drugs we think about. And then there are other places where there are still opportunity to develop drug products. And I think we will see more therapeutics. I think there are some structural questions that people have raised, which is, of all the things you could have tested, you have largely tested branded pharmaceutical products, even federal governments, and rather than older, cheaper, more available medications. I think that is a fair criticism because older, cheaper, available medications might have had a greater global impact, and they might have been the first studies that I ran more of, rather than specific branded products such as Gilead's remdesivir. That wouldn't have been the first thing I put all my efforts into. I think that there are also a lot of people who, believe that there's so many things you can think about that I think don't have great evidence, and I wouldn't prescribe yet because my view of medicine is that most of the things that don't have great evidence end up not working. But they have a lot of enthusiasm for people, and some of them have had a political dimension put on them. And those, I think, are the tough ones, these therapeutics that people feel strongly, it's politically divided, there's not great evidence. I think the right answer is to do the randomized studies for those drug products. I'm also careful, though, that I think that some people have been demonized those products. I'll just give one example. Hydroxychloroquine, I think at this point, we feel as if the totality of the evidence says it doesn't have a role to play in COVID-19. It doesn't work, at least in the doses it was tested and when it was given. It just doesn't work. But early in the pandemic, I think it was reasonable to think that it might work and to study it. And what you initially had was a lot of studies being run and a lot of doctors prescribing it without the studies. And that was something that I was critical of at the time, and I wrote some op-eds on. But then the president endorsed it, and that led to a backlash where not only people stopped doing it, they tried to make it hard to do, but they also criticized it so much that it was difficult to enroll people on the ongoing studies because they were so scared of it. That's not helpful either. I mean, when you have an unproven product, you want to be very neutral about it until you get the answer, and then you can talk about it, And I think that unfortunately took on a huge political component. He endorsed it, had spike in prescriptions, it was off-label use, but also a group of people kept talking about the harms, and that's not a good example, of how it should proceed.
Just to touch on that, sorry for extending it a bit more, do you think that the existence or possible existence of extremely effective therapeutics is a particularly strong argument against the proliferation of vaccine requirements or even advising someone to take the vaccine in the first place? specific to COVID-19?
I guess I would say that's an interesting question. I guess I would say that like the reason. I guess I'm a little skeptical of that, and I guess the reason I'm skeptical is that a vaccine and this vaccine, if it can be given very safely, and it has the effect size it has, which is huge against symptomatic disease, it's probably going to be very hard to beat. It's going to be very hard to beat, even by Paxlovid, which has a pretty. Paxlovid, in one of the early looks at the data, had like a 90% reduction in hospitalization among unvaccinated people, as you talk about. But one of the challenges with that effect size is very likely, I suspect, with more data and more time, will drift towards something less, as is always the case in biomedicine. And that still means that you're not. It's not like not getting it's not like not getting sick. You're still getting sick, and you're taking the pill. So I think that a well-developed, safe vaccine on a good schedule with some sort of optimization there is probably going to be a winner over a pill to take when you're in the throes of the disease. But that's just sort of an intuition that I think we'll know more in a year or two, I think.
I have one brief question, and this has to do with kind of cutting through the nonsense, right? And the nonsense of political identities and associative identities related to how people view our reaction to the pandemic. Who would you suggest folks should seek out to watch on YouTube, to read articles about, that cuts through the nonsense that necessarily isn't, politically driven by demagogues? So any suggestions that you have for folks, I think is very important, because people always ask that question, who would you talk to? Obviously you, but who else would you suggest?
Well, that's a good question. But one thing I would suggest is that, and I do this, I follow people who are polarly opposed on these issues, because it helps me to see how they're thinking and to help clarify, errors in my thinking or things that I could refine, or maybe a better way to state what my position is. If I were to articulate the spectrum of beliefs, I think that there are people who believe in strong restrictions continuing for a long period of time and being reimposed every year potentially, and strong mandates and strong policies. But I do follow the CDC director and the Surgeon General, and I follow, I think, some people who might be in that category. Some of the people I follow on that side, maybe Mark Lipsitz from Harvard, maybe some of the other more ardent signatories of the John Snow Memorandum. On the other end, people who are always pushing for focused protection, targeting the more vulnerable, people who are skeptical about mandates, people who are skeptical about masking kids. I put Martin Kohlsdorf and Jay Bhattacharya in that space. And then I think there's a huge middle ground where a lot of people fall along the spectrum. I think Francois Below from University College London is a very thoughtful commenter. I think Alistair Munro, who is a pediatrician in the UK, Rob Hughes, a pediatrician in the UK, Sunil Bopat from the UK. They're really thoughtful pediatricians who I think strike a balance on kids' issues. I think these folks who author The Urgency of Normal, Scott and Lucy, they're really thoughtful people about balancing restrictions and mental health. I follow Stefan Baral from Johns Hopkins University, who I think is sort of a centrist in this space. I think I follow Marty Macri and Cody Meisner from Tufts University and Hopkins and Tufts respectively. But I try to follow people all along the spectrum, and I think there are important insights and things pre-vaccine, post-vaccine are very different conversations to have. I also think it's still worth it to read the New England Journal. It's still worth it to keep, when you read about the news coverage of a preprint, to actually kind of skim the preprint. But that's my advice. I guess you should hear the diverse points of view, but not accept everything you hear.
And I think that's a good note to sort of close on, especially as we move forward with the Penn Anti-Coercion Coalition. We strongly believe that we want to bring a lot of people to the table of this discussion on COVID policy and vaccines. And, as you could probably get a sense from this conversation, not all of us might see these issues the exact same way. but to be able to actually talk about them in a thorough manner, preferably in person in these kind of settings where you really can have a productive back and forth rather than getting caught up in a lot of the sort of social media habits that we've fallen into around these things, I think is very important, especially for this topic. So you're welcome to follow our group. It is on Twitter and Instagram right now at anti_coercion. We'll hopefully be doing more events in the future of this kind. And I really want everybody to thank Dr. Vinay Prasad for joining us all the way from San Francisco. It's very generous of him to come and talk about these issues with us, especially since we've just started kind of organizing around this on the Penn campus. And I think I can at least speak for myself and probably everyone else in this room that this has been a very clarifying and enlightening session. So I look forward to more discussions of this kind in the future.
Thank you.